Can you see my screen?
Yes.
Okay. Wait a minute. Okay, this is okay. So, you see the full screen or not?
Not yet, the full screen. Now, yes.
Okay. And are the slides moving?
Yes.
Okay. Okay, so today I would like to discuss with you the next step of the ARIA guidelines. Usually the ARIA guidelines are simple because they say, well, these are the medications, you take them or not. Remember that we don't discuss immunotherapy because this is done with IACI by Oliver Farr. Well, Bernardo is involved, I'm not. So we only discuss medications. However, we do not consider in most guidelines the patient situation. And here we go from the 2025 with the medications for oral route and ocular route and with intranasal route. But we need to go into more in-depth value-added medicine and to rhinitis multimorbidity. And myself, I'm going to discuss with you why we should do that, and Bernardo will discuss with you how we are going to do it. So first of all, ARIA guidelines, current status. Well, it's simple. We started in 2020 in a paper published in a journal with an impact factor of 90, Nature Reviews, on allergic rhinitis. What it means. First of all, patients with rhinitis or asthma symptoms, usually they do self-care, and they do not assess either the pharmacist or the primary care of the specialist. However, if it doesn't go well, they often go to the pharmacist or to primary care, then to the specialist, and then to emergency care. So this is what is the scenario, and we need to understand this better. We have done in the past many different things: behavioral science, ARIA and the pharmacy, AIT care pathways, next generation grade guidelines, and digital care pathways. So this was the past. But now we want to do it in a different and more modern way. And in fact, it is mHealth, guided self-management. This is what we need because people in allergic rhinitis want to do self-management helped by mHealth and the physicians. So using symptom medication scores, monitoring, action plan, clinical decision support system, and shared decision making, we want to do an mHealth guided self-management. And this will be the end result of ARIA 2026. Moreover, we also need to embed planetary health, air pollution and neurobiology, climate change, biodiversity, nutrition, possibly physical exercise, and non-medical intervention. So, ARIA 2026 is not related only to medications and to immunotherapy with what the IACI will say, but it is an integrated project. However, we need to include artificial intelligence, and we have already started. So this is digital enabled, person-centered, artificial intelligence assisted. And in fact, we published in 1997 and then in 2023 the Mobile Airway Sentinel Network mHealth app. What is the end result of this? It is the treatment of untreated symptomatic patient and treated symptomatic patient. And I think that none of the other guidelines, which have been published even since then, have considered untreated and treated patients, because this is totally different. And this is an algorithm that we want to revise at the end of the day with what we're going to say today. So, first of all, we propose the concept for the development of person-centered, digitally enabled, artificial intelligence-assisted care pathways. And this was published in the JSM practice 2 years ago. We had 3 steps. The step 1 is selection of questions. The step 2 is the grade approach with clinical trials and real-life recommendation. And the step 3 is the consensus with values and preferences, AI, and planetary health. So this is how we've built ARIA. And this has been published 2 years ago. Then we published this month in Allergy the methodology for the development of the ARIA and EACI 2024-2025 guidelines, from evidence to decision frameworks to digitalized shared decision-making algorithms. So you see, we're going far beyond what guidelines are usually saying, well, you should use this medication versus the other one. And also, you should remember that now we're working with EACI together. The first thing was, in fact, a paper we published after 8 months of, well, the paper was very simple. In January 2024, I discussed with Bernardo that we needed to include artificial intelligence in real-life data. And Bernardo, within a month, with Rafael Vieira, made a paper. Well, this paper was published in the Annals of Internal Medicine, very big journal, September 24. So this paper made a big difference. Why? Because were the ARIA questions, were the questions from the panel, were the questions based on mass care data, were questions based on Google Translate data and generated by large language model. And we put all these questions together, and at the end of the day, it is simple, that we had 14 questions coming from ARIA 2010-2016, 10 questions from key opinion leaders, 9 from mass care, 10 from Google Translate data, and 9 from large language models. So we have really something which is derived from the patient. And in fact, this is the guideline. This was from the science. But now we need to go to real life. Of course, the questions are based on real life, but also what we're going to propose should be based on real life. And this is why I proposed value-added medicine. Well, this is not new. In 2022, I wrote a paper with Monter to me with really something very important on added value medicine. And it was the ARIA approach of value-added medicine. And the important issue was as-needed treatment in allergic rhinitis. You know that as-needed treatment is well accepted in asthma, but in allergic rhinitis it's not yet accepted. And in fact, none of the medications are listed for value-added medicine. So what we did, in fact, we proposed to use mass care. And mass care is the only app accepted by OECD and the EU using a validated performance assessment network. And in fact, only 13 best practices have been accepted, but only because they focused on those of key strategic interest to policymakers. So what we're doing with ARIA and with mass care is for interest to policymakers. For value-added medicine, we have different steps. First of all, adherence. Well, we started in 2019 with only 12,000 users. Now we have 74,000 users. And we defined 2 groups of adherence, PDC and MPR. These 2 groups, in fact, were defined in only 17% of the users, because we couldn't get other data except in the 17%. So we're already discussing only 17% of the people who are using mass care. And then only 12% of them had an appropriate adherence level. So in fact, ladies and gentlemen, very few patients in this particular study were adherent to medications. So we cannot use, well, in fact, the randomized controlled trials in order to assess this. Moreover, in the same study, we found that many patients were using self-medication. So, if you're using self-medication and little adherence to the treatment, in this case, you need to go to not to a long-term treatment that you will not take, but to a treatment that in fact very few patients are going to do. Then we did a second study which was recently published, and we assessed the adherence to treatment in allergic rhinitis during the pollen season in Europe. In fact, we had 10,000 weeks with oral antihistamines, 5,600 intranasal corticosteroids, and 3,000 in azelastrine fluticasone. We didn't get olopatadine mometasone because the medication was introduced later. And you see that we had some quite severe nasal symptoms because VS median was 40, 41, and 39. And in fact, the self-reported asthma was 15%. First of all, we're able to compare fluticasone furoate, mometasone, and azelastrine fluticasone. And in fact, people are adherent of over 80% in 26%. These are patients who had filled the app regularly for a week. So probably only 20%. And then you have 26% of these patients who are adherent with fluticasone, 35% with mometasone, and 31% with azelastrine fluticasone. So 20% of 20%, this is below 5%. So really, in mass care, in 35 countries, the adherence level is lower than 5%. So we cannot continue to say, take a medication regularly, because we do not do it, the patient do not do it, and ourselves, who are physicians, using what the treatment we are prescribing, we do not follow it. At least I could not do it. So I felt that the former ARIA guidelines were for very restricted people. The next point is adherence to treatment, and you see that, in fact, there are differences for VS nose and VS eyes according to control of the disease. This is an interesting slide because it shows in 51 patients who were followed for 6 months that those who started with an adherence of 80% of days usually maintain this adherence over 6 months. But as soon as you have low adherence, the adherence level reduced, and there are many patients who are never adherent to the app, even though they feel for 6 months not adherent to the treatment, even though they feel for 6 months the app. The second point is patient satisfaction, and this is a new concept that we started 2.5 years ago in mass care, and we have already quite interesting data. Well, first of all, we had, this paper was published in allergy this month again, so we had 3 papers published in allergy this month. And we had something like asthma, CSMS, medication. Sorry? Desiree, you wanted to say something? Okay. So, this is the difference between monotherapy and co-medication. And you see that satisfaction of patients is higher when they take monotherapy than co-medication. You can see in green arrows the different classes, but only intranasal antihistamine are not as good. Why? Because in fact, with monotherapy and with the low dose, people are not very satisfied. And then we're able to identify differences between medications, individual medications. So now we know with this data what is the patient satisfaction, and it is shown that patient satisfaction levels are associated with mono or co-medication. And these are the data. So Bernardo found something very interesting, in fact, and what he did, he assessed the control on the previous day. The control was good, partial, or poor. And the next day, he assessed satisfaction. And you see that satisfaction is decreasing from 90% of patients to 40%. At the same time, he assessed co-medication, and co-medication is increasing. So it is clear that with satisfaction of patients, we have some endpoints that can drive the guidelines. And also, INCS plus ANAH mainly administered in patients with poor control, which is expected. So now we have some real-life data with new evaluation. Then we're able to evaluate the medications. And here we took the group. What is extremely interesting, it is that on the left-hand part, on the right-hand part of the slide, if you take intranasal corticosteroids plus oral antihistamines, you are less satisfied than oral antihistamine alone, than intranasal antihistamine, intranasal histamine, than intranasal corticosteroids. So in fact, the co-medication of INCS plus OAH in real life is found to be less effective. And this is something which for me is quite important to include in the guideline. Then we have monotherapy versus co-medication. Well, this is a slide I always present. It is on 10,000 users and 9,000 days. What you can see, day 1, day 2 to 14, 15, all days. So the best treatment is no treatment. Why? Because patients are highly satisfied and they do not take a treatment because they do not need. And this is because patients use the medication not regularly, but on demand. Then you have a group of 3 medications. The first one is intranasal corticosteroids, intranasal antihistamine, light blue. Intranasal corticosteroids plus intranasal antihistamine plus other in darker blue, and intranasal corticosteroids alone. And then we have a group of 3. It is oral antihistamines. It is then intranasal antihistamines plus oral antihistamine, and intranasal antihistamine plus oral antihistamine plus other. So you see that when patients are using co-medication, especially oral antihistamine and intranasal corticosteroids, this is because they are not satisfied, as I showed you, but also because they are more severe. And the MID was over 11, so it was in fact highly significant. The next point is that in our database, this was in 2022, the best treatment is of course no treatment. One medication. If you take intranasal corticosteroids or as a flu, it's better than the MID. And if you take oral antihistamine, it's not as good. But if you take 2, 3, 4 or over 4 medications, always it is over the MID. So we need also to account for this. And in fact, these are the number of drug groups reported by patients in European users. And this again is in 13,000 users. And you see that when you have 2 drugs, 3 drugs, you see that at least 25% of patients only use 1 drug during the pollen season. And when, one class of drugs, sorry. And when they use 1 drug, you see that they use up to 6 drugs in the same class, in particular for oral antihistamines. So once again, this has to be considered. The next point is symptomatic treatment. Well, this study was unexpected, and we assessed when patients were using the app, and this is 13,000 days, 13,000 patients, 222,000 days. Every year, including COVID in 2020, patients reported the app during the pollen season. So when they are not well, patients do not use the app. And when they are well, they're using the app. But what are they using? Oral antihistamine or the co-medication between oral antihistamine and intranasal corticosteroid. So they are not using the right treatment. And this is what we need to consider and to change. We need to ask patients to consider this. And this is even more important because we assess this in Italy, France, and Germany. In Germany, there was also a lot of intranasal decongestant. But you see that the peaks are the same. And in France and Italy, the medications are the same. However, patients think differently. In another study reporting Google Trends, we found that in Italy, patients think allergy. In France, they think allergy and allergic rhinitis, and then pollen, sorry. And in Germany, they think allergy, allergic rhinitis, and pollen. So there are cultural differences. There are patients thinking differently, but they treat themselves the same. And they also buy medication differently. So this is another study we published in Clinical Experimental Allergy. And we assessed the medications bought by the patients, both OTC and prescribed, in 2019, sorry. And what you can see here, it is that in France, in Germany, and Italy, the patient buy different medications. Of course, in Germany, they buy some intranasal intranasal decongestants. But the level of azelastine triticazole is far different between the two. And look that in Italy, patients buy little intranasal corticosteroid probably because they are not well reimbursed. So patients buy different medications, think rhinitis differently, but in fact, they treat themselves exactly the same according to symptoms. And this again has to be reflected in ARIA guidelines. Moreover, some people use the treatment but at the pharmacy level. And with Eric Van Gans, we did a study and we found that in fact, the treatment prescription for allergic rhinitis and asthma are not associated what the patients report. So the pharmacy filling is not necessarily a reliable criteria. Now we have the change in treatment. So what we did a longitudinal study in 16,000 weeks in something like 2,590 observation with complete observation. So you see that we have a big database. The total data reporting rhinitis was 48,000 days, so 33%. Asthma, 37%. Conjunctivitis, 74%. Well, first of all, on the left part of the slide, you can see the cluster analysis, C1, C2, C3, control patients. PC1, PC2, uncontrolled patients, partly controlled patients. U1, U2, uncontrolled patients, and V1, V2, V3, patients who during the week change their treatment. If you take C, PC, and U, you don't see a lot of difference, except that maybe oral corticosteroids are given more often in those who are partly controlled and uncontrolled. This is surprising. However, if you go to the part B of the slide, you see that the number of schemes differ considerably according to the control of the disease, from 85% with one scheme to 55% with one scheme when you have patients who are uncontrolled. So patients take medications not well defined, but they increase their medications when they are not well. And this again has to be considered in our guideline. Then PRN versus continuous treatment. We need to check this better in the end. I now want to go to rhinitis multimorbidity. Well, this is a study which I think is essential. I'm sorry, the title has been, it's a paper published in Allergy. And what we found that when you have probable asthma or occurrent asthma, the VS nose and the VSI is higher. When you take the medication, patients with no current asthma, that is to say rhinitis, have a high level of oral antihistamines. However, when patients have asthma, they take intranasal corticosteroids as they flu and oral antihistamines. And the number of reporting medications differs as well. So there is a clinically meaningful difference between asthma and rhinitis in the control of rhinitis and in the medications of rhinitis. And if you take different countries, Brazil, Mexico, Portugal, Spain, France, Germany, Italy, Greece, Turkey, Poland, Netherlands, and Lithuania. So, scattered from the north to the south of Europe, and in developing countries. And you see that there is no major difference. But look at the level. The levels are quite high because they may be from 60 to 14 in Brazil, for example. So what we understand here, it is that patients are, well, patients are well controlled, are better controlled, sorry, with rhinitis than with rhinitis and asthma. Now we took a different study. It is the study in asthma. So we clustered asthma as A, B, C, D, and D3. D3 is rhinitis. And you see that, in fact, VS asthma is very low in this one. A is treated asthma. AB1 and B2, sorry, are treated asthma from uncontrolled, partly controlled to well controlled. And you see that the treatment levels in asthma also are important, but ICS/LABA are very common. What is very interesting, it is that in the graph below, you have 29%, 21%, 15%, and 12.3% of patients with intranasal corticosteroids and oral antihistamines or azelastine and fluticasone versus in D3, 7.9%. So if you cluster asthma, if you cluster rhinitis, you get the same data. And in fact, this strengthens the fact that rhinitis and asthma are distinct diseases with distinct genetics. In fact, asthma alone, rhinitis alone is IL-17 and toll-like receptor, monosensitization, no asthma, and rhinitis plus asthma is IL-33, T2. So we have two distinct diseases, and no one has proposed to assess the disease differently. And this is what we want to do with ARIA. And another study, you see here, total person work impairment with allergic rhinitis per level of rhinitis control. Simple. You have rhinitis only and rhinitis and asthma, totally different. And this is another study with the median cost, rhinitis alone and rhinitis in asthma in 27 countries. And the median weekly cost of allergic rhinitis due to total work impairment considerably differs in patients with rhinitis and asthma in red dots. So, ladies and gentlemen, I think that we need to understand this much more. And we also have consistent trajectories of rhinitis control. And this is what I showed you later. But what you can see here, it is that when you have controlled rhinitis, C1, C2, and C3, you have low level of all symptoms. For partially controlled PC1 and PC2, in fact, you have a greater level, and just at this level, asthma starts. But in U1 and U2, asthma is much higher. So again and again and again, this is a difference. And I think that we are doing now a study with WOW on distinction between asthma and rhinitis. I would like to finish my presentation by, population studies. Constance is a general-purpose population study, national representative sample of 200,000 adults. And we had data on 4,675 participants. What we could find, it is the blood eosinophils in allergic rhinitis alone and allergic rhinitis plus conjunctivitis are lower than in asthma and rhinitis and asthma, rhinitis, and conjunctivitis. So once again, we find that there are two distinct diseases at every single item found. And if we checked persistent rhinitis, moderate severe rhinitis, ocular symptoms, or oral antihistamine and intranasal corticosteroid, you will see that in particular, for the latest one, that there is an increased level of oral antihistamine and intranasal corticosteroids when you have asthma. So once again, we need to consider asthma in the guidelines. And this is another study. It is the EGA study. So it's a study in initially it was a case control study followed by a longitudinal study. And you see that the number of allergens is ranging from 10% in rhinitis and no asthma to 65% in asthma and allergic rhinitis. And once again, this is another criteria. So, ladies and gentlemen, what I've tried to tell you, it is that first of all, we need to go from the science we have now to real life, using different endpoints, and also to consider asthma and rhinitis alone as two distinct diseases in the guideline development. Now, I'm delighted to open the field to Bernardo.
Thank you very much, Jan, for the presentation. I'm asking whether you can see my slides.
Yes.
Okay, perfect. So now I will be talking about the next paper of ARIA 2024-2025 guidelines. So just as a form of introduction, as Jan has been presenting, we have published the concepts for the development of the ARIA 24-25 guidelines. Then we went to methodology and we have published the paper describing the methodology of the guidelines in allergy. We then went to intranasal treatments, which has been published this month, and we have the guidelines on oral ocular treatments, in which we have incorporated the feedback that you submitted and that we hope to submit soon as well. So we have 3 papers published, 1/4 which is finalized, and we are starting to work on the next one. So on part 3 of the ARIA 2024-2025 guidelines. And this part 3 will be focused on co-medication and as needed strategy. So as Jan said, this is something that it's very important. So it's not just a matter of knowing which medication is more efficacious or safest. It is also important to have recommendations based on the actual strategies that we expect patients to do. And so the 4 questions that we will be addressing in this 3rd paper is whether we should use a combination of oral antihistamine and intranasal corticosteroid versus nasal corticosteroid alone. If we should use oral antihistamines plus nasal corticosteroids versus oral antihistamine alone, if we should prefer co-medication versus medication dosing in patients who are poorly controlled when treated with a single pharmacological treatment. And finally, the question on long-term or chronic treatment versus as needed treatment in patients with rhinitis. And I will be starting with co-medication versus medication dosing, in which we are doing a systematic review with dose response network meta-analysis. So this is an approach in which we can perform network meta-analysis and in which we can explore the role that increasing the dose of a medication would have. And the protocol has already been published, and we have some preliminary results. Particularly, preliminary results focus on the comparison between giving twice the dose of a medication, twice the dose of the standard dose of medication, versus doing a co-medication strategy. So adding an additional treatment to the existing one. And this is just to show that we have coded the doses in which medications are most commonly used, and we compared doubling the dose versus the co-medication strategies. So in terms of preliminary results, we have found that doubling the dose of an intranasal antihistamine was associated with higher efficacy than adding an oral antihistamine, this for the total nasal symptom score, while for intranasal corticosteroids, it was more or less the same to double the dose or...
Bernardo, we don't have your slides.
You are not seeing my slides?
No.
We don't see it well.
Yes, I can see the slides.
And you can see them moving?
They are moving?
Yes?
Yes.
Okay.
I can see it.
Yeah, I can see as
I
well.
don't know why I cannot see them, but that's not the problem because I know them.
Okay, thank you.
Okay,
So for the comparison between nasal corticosteroids and oral antihistamines, we found that it was more or less the same. So the difference were trivial for nasal symptoms and quality of life. Uh, and this was something that we also observed when it comes down to comparing doubling the dose of intranasal antihistamines or using a fixed combination of nasal antihistamines and nasal corticosteroids, which we found that were more or less the same. While for corticosteroids, doubling the dose of corticosteroids may have some advantage in relation to the use of fixed combinations of intranasal antihistamines and corticosteroids, at least for nasal symptoms and rhinoconjunctivitis quality of life, because for ocular symptoms, we found that it was the same. Then, as for oral antihistamines, we observed that doing co-medication with intranasal corticosteroids was better associated with higher efficacy than doubling the dose of oral antihistamines, at least for nasal symptoms and quality of life, while the addition of leukotriene receptor antagonists had a variable effect in relation to doubling the dose of oral antihistamines. For some oral antihistamines, there was a bigger improvement. For other oral antihistamines. Actually, doubling the oral antihistamine dose was preferable to adding a leukotriene receptor antagonist. And please note that this is just focused on the efficacy side, because, for example, we may know that, let's say, in terms of fixed combinations of nasal antihistamines plus corticosteroids, they have some other advantages that doubling the dose of corticosteroids would have, for example, in terms of their fast onset of action. So at the end, all of this needs to be considered, but this is just to show you the efficacy perspective. As for safety, we found mostly trivial differences. So it's mostly the same doubling the dose of a medication or doing a co-medication strategy. The exception is with montelukast, in which doubling the dose is worse than adding an oral antihistamine, and with some oral antihistamines plus intranasal corticosteroids. Then, one of the other questions that we will be addressing is comparing continuous treatment versus as-needed treatment. And Jan has already discussed a lot of important stuff about this question. We will be approaching it in a systematic way using the evidence to decision framework. And here there will be some criteria which will be crucial for our recommendation. So, of course, that we will be considering desirable and undesirable effects. This means the efficacy and the safety of the interventions, and we are doing a systematic review on that, looking at the existing randomized controlled trials. The protocol has been submitted for publication, the search has been completed, and we are now doing the study selection, being on the screening stage. Then there will be some aspects that we will need to take into account in terms of resources required and impact on planetary health. So we know that as needed treatment is better in terms of the impact for the planet, because we require less use of resources in terms of intervention, and it's also better in terms of the costs that patients would need to have with the intervention. So actually, we can model how much we could save with an as-needed approach, both in terms of in monetary terms and in terms of the impact for the planet. So these are two important aspects for our decision. And finally, we will use mass care to inform on acceptability. Jean has presented several studies on mass care in which we evaluated as needed treatment. So we need to understand with the data the frequency of patients that can actually achieve a good control with as needed strategies, as well as when you don't do any medication, what is the frequency of days in which you actually can maintain a good control of the disease. So this is something that will be important as well. Finally, we have some questions which are more similar to the ones that we usually discuss within the context of the ARIA guidelines, and for which there was already a first version of TTD, which we are revisiting with new evidence, in particular with new evidence on costs, now that we have the data on the survey, for example, and with better approaches for synthesizing the evidence, because so we can have now better estimates for the meta-analysis. But so far, this is provisional in the first evaluation of this comparison or between intranasal corticosteroids plus oral antihistamines versus intranasal corticosteroids alone. We issued a conditional recommendation in favor of intranasal corticosteroids plus oral antihistamine. So there seems to be a gain in adding an oral antihistamine to an intranasal corticosteroid. And in terms of undesirable effects, the difference seems to be trivial. So overall, there seems to be a favoring of this strategy, particularly in more severe patients, but we need to reconfirm that now that we are revisiting this ETD. And the same goes for the comparison between oral antihistamines and intranasal corticosteroids versus oral antihistamine alone. There seems to be an gain in terms of efficacy and moderate effect, and trivial differences in terms of safety, in terms of undesirable effects. So overall, this seems to favor this strategy, once again, in patients who are not so well controlled. So overall, this third paper, it will be very important for the design of the algorithm, because we will be focusing on those patients who are more severe, who are not so well controlled with a single treatment, and we'll be exploring whether co-medication, increase of the medication, are the more adequate strategies on the one hand, and on the other hand, we'll also focus on patients who are less severe and most likely will be able to manage their disease on an as needed basis. So this third paper will be an essential piece to design our algorithms based on the severity of the disease. Thank you. I don't know if there are any questions.